that system had been missing any part of it, not in the surgical department on the third floor someplace else in her urgent department. Trauma surgeons. It doesn't do any good to have these trained trauma surgeons unless you have a prearranged coordination between the ER, surgery, anesthesia, blood bank. Where I worked, if you had a major trauma come in, it went overhead on the last floor of the emergency room. Make sure that wasn't involved. I mean, in the EMS center, more than 10 people called 911, that's our trauma emergency number, and started the process for someone to get help for her injuries. Um, Had that not occurred, she would still be laying there. So you need to understand that, you know, somebody is injured and everybody needs to know how to enter the U.S. 911. In one case, I forgot the number. Like,
During the process of
okay. So that's going to be tough because that would mean everybody would have to memorize that seven-digit number, and that's hard. So, as I asked in the last question, when a 14-year-old bicyclist who passes you in a car accident on the side of the road, what number to call? And then once they call,
You would just call 911, we go, and then the police dispatcher. There's, yeah, still a delay in that process.
plane has already set up and flown. We're in the air outside the room that she's going to be in. That's right. Ultrasound machine Took a lot longer, but precious. I forget how many he said. Trauma surgeon. Be able to come into the for any other teams, any others. By the way, this is the system available to her.
any comments at all, David?
Donna, I would like to have you come and lecture our group and our trauma surgeons about the need for coordinated care. So what really struck me about your talk was, I think this remains a weak spot in all but the most highly functioning trauma systems. It's the coordination and to have people who really have the mentality of showing up when called without having to be prompted or cajoled. It's that represents the pinnacle of coordinated care. And I'm thinking like um, everything fell into place for your niece. And we all have seen, including Belize in Vancouver, everywhere, cases where that didn't happen, and the consequences are really disastrous. So,
I'm so grateful that everything did fall into place because there's multiple different steps, but any one of those steps, if they fall apart, then the whole thing falls apart. And that coordination between the emergency was crucial. I would say in the middle of the night, and I could never get a surgeon to come in. And I wasted my time on the phone trying to call them in, and they'd say, well, the nurses will just call the department head. And I'm like, but I'm wasting my time. I need to make a patient, not on the telephone. And so to me, having people speak ahead of time and making a plan ahead of time, and that would be, the head of the emergency department speaking with the head of, trauma department and saying, listen, this is our protocol. We have a problem with it. This is what's used in other centers. What would you like to change? And so that everybody is on the same page. Um, Once that happened, my life was so much easier, and I think patients did so much better. I mean, patients actually not fighting you with phone in the middle. It really does make a difference.
I'll just weigh in with one more thing, and I think probably Rigo and Ronaldo will chime in. Is for the new residents, it's often the case that you really left with maybe a person, and you have to manage the resuscitation as the team captain, sometimes as the only doctor, and that includes airway, blood products, critical beds, um, hopefully not the ventilator, but certainly the airway and minor surgical, interventions, including venous access and ventral access. But during case, um, and sometimes you have more than, in a mass casualty situation, you're in a triage capacity where you really just things for the sickest patients. So I'd be interested to hear Ronaldo weigh in on that.
Good to see you. Hey, I got Belize here. So I'd like to say two things about one is taken from Dr. Benicia is to have a system in place, and the next one taken from Dr. Esler, which is to have people who goes for it. All right. So here in the U.S. you have a system of 911. So the South African have. I remember once Trevor Noah, is a known comedian. He said in South Africa, if you call the 911 and you tell them, look, there is a man out there. I want you to come and help. So the response to that is, go talk to the man. Find out what he wants, right? So they have a system in place, but they don't have people who goes for it. That's important. When during the break, we had a chance to shut off the bricks in Milwaukee. That road, and they would stop eating, they would stop buying, they would stop whatever they're doing to go for the call. So once they're called,
one of the things that springs to mind on it was back, about 12 or 15 years ago, the Ministry of Health here in Belize did a study on the cost to the Ministry of Health of RTAs. And they found that whenever and it was an imperfect study because they were not able to capture all the costs. They found the cost they could capture at that time was not about 30% of their entire Ministry of Health budget went to basically taking care of RTAs because of again, that second and the disability associated with those injuries, the deaths associated, the income that was necessary to support the so at the very beginning,
Think about the initial money to set it up and get things initially, but those things could have been improved by good care in the very beginning. And that, I think, makes a huge difference. And that to me is critical. Thinking all the time and think how amazing that, she made it with that horrible head injury and, was.
you guys have any questions or comments? That's okay. This is, we got to be able to hear you and see you. Can't be shy. This is Dr. K.
Hey,
Hi, good morning, everyone.
Good morning.
Well, it's very interesting, all these organizations for the trauma care that you have, but being a emergency for almost a year now, I guess, it's a lot of challenge for us here with travel here. We do have a lot, especially with other departments. You being willing to help and help us here is having a 5 10 minutes here.
well, I think that's part of the thing. You said it right there. It can't be this said that this is this is your child to be cared for. And if you don't want to, if you want to have a system working, you have to make a system that works and you participate in the other half of it, not just the emergency room. Because as I said, coordination between me and you take care of you and your group and your system, and we're not going to help you out and just take care of our. And medicine is dependent on happiness.
It
And
was,
this is how I started. I worked there. So when it's opportunities and how everything surgeons available as we do. So, going through and you know,
anybody else? We're running out of time, so this is your last chance to comment or question. I will send Dr. Venezia's lecture to you so you can review it and share it with your colleagues. And thank you so much. David and Saran, I'm going to send you another link. This V, Saran, and Mora. Hey, Saran. Can you turn your computer around so that Sharon can see this way? Can you see you can see me, right, Sharon?
I can see you, yes.
Okay, I'm gonna step out of the way and Ronaldo's gonna step up. And
Okay.
I'm gonna just get his PowerPoint ready to go here.
No, I can't see the PowerPoint. I can only see like a little bit of it.
Yeah, I don't know if I can, I don't think I can share that with you. But it's on the screen behind us. And kind of turn this. Can you see that a little better?
Better. I can see it a little better now. Yeah, just a little bit. Yes, that's better.
Okay. So, do you need this? Do you need the mic up here? Okay, I'm going to trade places with you. I'll hold the mic for you so you don't have to. But if you want to use this as the pointer, just push this red button there. That'll kind of do that. Okay? And just tell me when you want to advance the slides, and I'll advance it for you. Okay, we're just dealing with the feedback here.
I think it's getting better now. There's no more feedback and the sound sounds good.
David, do you work today?
I've had, I think 4 shifts in a row, and I'm off for a few days.
All right.
So yeah, it's nice to wind down a bit. It's been really, really busy.
Okay, I think are we ready to go, Mr. Reyes? Maura, Saran, you're all ready? So I will turn it over to Ronaldo here.
Okay.
Yes, I'm ready.
Good morning, everyone, again. Today's case, I brought up a case that is a real case that came to KHMH way back in 2018. It came to us as a referral from the South. So this is a 59-year-old male patient who was referred to KHMH to Carl Kirchner Hospital from Danbury Hospital. We call that the Southern Regional Hospital. So the patient was, the story is that the patient was riding his motorcycle towards home when he fell off the bike. Patient lived in the Punta Gorda rural area. So on arrival to KHMH, A&E, the paramedics placed him in one of the trauma beds. He already comes with an neck collar, had an alcohol breath, and has been given oxygen by nasal cannula. Let me just develop a little geographical site to understand better. Southern Regional Hospital is around 100 miles away from Belize, and where the patient had the accident is 50 miles away from Southern Regional Hospital, meaning like 150 miles away from Belize. Initially, he was taken from the site of the accident, PG, Punta Gorda, into the Southern Regional Hospital. On arrival, so the patient came to us after being seen already on a referral site. So,
No problem. Just as long as you speak up so
Right,
that everybody can hear.
So when the patient arrived at KHMH A&E, patient is awake, but it's confused, right? And by the way, confused does not mean. Hello?
It's recording, okay, for that.
So once again, when the patient comes to our emergency departments, he was confused, nauseous, agitated, localizing pain to the right reason, and his eyes open whenever we talk to him. So patient says his name, but doesn't recall his last name. When his wife asked him how many children they have, he said 3. According to him, his son and daughter. He had a son and 2 daughters. According to him, they were both all in the U.S. But the
But
wife
the
said
wife
that they
said
were
that they were
all
all
in
in
Canada.
Canada.
So it was
So it was
evident
evident
that
that he was confused.
his
On his
physical
physical
findings,
findings,
he was
he was
confused.
confused.
Notably,
Notably,
lungs well
lungs well
ventilated and
ventilated and
abdomen were
abdomen were
unremarkable.
unremarkable.
Deformed
The
right
form
wrist,
right wrist,
pupil were
pupil were
myotics.
myotics.
He has no
He has
past
no
medical history
past medical history
and motor.
and no motor deficit.
His vital
His
signs
vital
on
signs on arrival at
PHMA was
PHMA was
110/70.
110/70
Blood pressure,
blood pressure.
heartbeats were
Heartbeats were
46 beats
46
per
beats
minute.
per minute.
His breathing
His
was
breathing
18,
was 18. Temperature was
98.2
98.2
Fahrenheit.
Fahrenheit.
Oxygen sat was
Oxygen sat was
99,
99
and
and
glucose was
glucose was
103.
103.
Let me just
So let
open
me
the
just
floor
open
for
the
all
floor
of us.
for all of us. This instead of
Be a
be
case
a case
presentation should be a
presentation
case
should be a
discussion
case
because this is
discussion
for all
because
of
this is
us.
for all of us. You might
Cover
want to cover
yourself
yourself
and
and
what is
what
coming
is
and I'm
coming and
talking
I'm
to you,
talking to you,
the trainees,
the trainees,
what comes to your
what comes to your
mind
mind
as you go
as you go
on this case?
on this case?
First thing is trauma. So, um, in this case, it's coming in from some regional hospital.
Say your name.
Uh,
It's recording.
Oh, I see.
Dr. White speaking, right?
So,
So, in this situation, you said that a lot of things you have to take into consideration. The distance from one hospital to the other. And like the doctor said earlier, time wasted is a life wasted, right? Organization, you're moving from regional to state dimensional. So we have to be,
Instead.
we, we let the nurses know, right? Let the doctors know. Call radiology if needed. Call doctors, specialists if needed, right? And have a bed set up for the patient. So when the patient comes in, right? Now in this case, we're looking at a trauma. We noticed two things: the patient was drinking and the patient was on riding his motorcycle, right? So riding a motorcycle could cause a severe type of impact. In case patient comes in, we need to know, we need to take into consideration, go physical examination, look at the glass of the patient, if the patient is confused, right? Patient came in with a color already. We need to see X-rays, or if we don't have X-rays, we need to ask for or request for X-rays. Patient had a deformed right, right? Patient is complaining.
No wax left. No.
Okay. Yeah. Vital signs are good. The heart rate was 46 beats per minute, right? Respiratory fluid, temperature, saturation were all good. Now, in this one, about history, anything else that you need that you can know? Everything in the consideration are complete.
When we receive referrals, we usually ask because a referring doctor would call us here at the emergency and he would tell us if X-rays are done, if they have called any usually they're supposed to already call a specialist who is already who has accepted the case. So as soon as the case is here, then we call them and they're supposed to be here. So by the time the patient arrives here, sometimes we already have well pre-assessment of what has been done in the referring hospital, the regional hospitals, and this would be X-rays. So if was any fractures, they would have already told us. So we would already have an idea of more or less what is going on with the patient. We receive vitals even before the patient leaves the other hospital. So if the patient would have been intubated as well, we would already know. So, but sometimes we don't have full details because some hospitals, I guess they don't have everything, just like we don't have probably a CT scan working.
So,
We won't have those things. So,
A couple of questions. First of all, do you
do you
know when
know
this patient arrived? Do you know how long he had been since the accident, since his injury?
We normally are being called out
we know who is coming, and if the patient comes along with a relative, that's when we can find out exactly the time when the accident.
So this
happened.
patient was transported by ground ambulance.
That's right. Just to cover up the referral form.
3 hours.
So
If
right.
usually, if we're coming by ambulance from southern to here, it usually takes 2 to 3 hours.
Right.
If
So,
a plane is available, then it's 1 hour.
so just to cover up that case, right? Remember, we're focusing a lot. Remember, this case is already a bedroom, right? So we have different approaches, right? You can go the way you took the road, right? Make sure that this and this and that, or you can go and see the patient and then take it from there. But just to cover that up with respect to the referral. So the referring doctor's getting in touch with the surgeon on call, the surgeon is making the case to come. And being given is the neck collar, right? Right, and oxygen supply. Right, that's pretty. It's not ventilated. It's not ventilated. Although the patient is already in bed, and yeah, the
It's coming.
X-ray on the referral that wasn't working. Right, so there's no X-rays. So look carefully. There are information like that. You can actually tell what this guy has. You know. Look at it. Dr. Ho said it right. Look, this is a guy who fell off a bike. He's confused. And confused does not mean responsible. It's confused. He says, we can do what is working, right? Because that will tell you what to do next. I mean, this is something that we have to see. And he mentioned too. Okay, he's confused, and then his heart rate is so he's seeing the problems already.
So one of the critical points, especially with this type of case, especially with somebody that's had a head injury, is determine whether the patient was a helmetless rider or had a motorcycle helmet on. So that's, again, a very, very important aspect, because helmetless rider is going to raise your index of suspicion for a worse or bad head injury.
I didn't state it, but he had a helmet.
Okay.
He had it. But there wasn't any evidence of bleeding on the head.
Okay.
So, okay, let's go step by step. Okay. This is like just, I'll give you a for instance, right? If you know about DIS as a surgeon, right? I've done one group almost 18 years, way back when I was younger. But the guy knows so much details that to man, he said, as I go through, the only way he knows so many tricks and so many things is if someone who's older than him, maybe teachers, leading or show, teaching all things. So this is where we are. They say, any one of us, anytime. So I'm exposed to that, exposed to a case, then the second case much easier. All right, so let's take a look at this one, all right? So he's been brought to us at A&E, placed in bed. He's confused, nauseous, agitated, confused. That's the key word right there, right? When we're looking at the glass one, right? The mental status, right? What is confused? Well, confused goes to verbal response, right? And verbal has 5 elements. Someone who talks clear like us, we got 5. But someone who is confused, we got 4. So we got 4 points of GCS already. And then he localizes pain. He localizes pain. What does that mean? That is motor, right? Motor has how many? 6. If he moves freely, that's 6. But if he localizes pain, that's 5. So we got 9. And then his eyes opens on verbal response. Somebody with Glasgow 15, just like you and I, you say, I open. But if he only opens with pain, then you got 3, right? Sorry. We got 4. I 4, right? 4. So there we go. So we got confused. How many points we said? 4, right?
Sorry. It'll come back. It'll come.
Right, minus 1. But that is 12. That is correct. So now we have someone who has fallen off a motorbike that comes to us with GCS of 12. Right off the bat, we said, look, man, we need to run with the CAT scan.
And a GCS of 12. Exactly. I mean, again, the GCS now is at least 3.5 or 4 hours post injury.
So as we went for the referral route, there was no statement on the GCS. Right? So we didn't know. But this is what we have now. Right? So think, for instance, right? What the key thing here is I have the patient. What are we supposed to do? What our plan of action? What is our diagnostic tools? What do I need to do to find out exactly what's the case? Right? So he talks. I've been confused. His sat is good, right? So his airways is good, right? His breathing is aiding and his lung is well ventilated. So his beat is clear, right? If you look at the BP is good, but the heartbeat is low. So this is where we stop. Remember the pneumonia of ample? Are you familiar with that pneumonia? Ample? Ample? No. AMPLE?
Ample is easier to remember.
Ample sample. Okay, I remember ample. Ample stands for A for allergies. You want to find out if the guy has allergies or not because of the meds you're about to give. M, it's for what kind of medication he's taking. Is he on hypertension taking beta blockers? That could have put down the heartbeat. So P, it's past medical illness. Does he has any past medical illness? L, lost meal. You want to know in case you want to put an NG2. Maybe he's on a OP case, right? And the E for ample is the event that leads to the condition that we find him now, right? And that event was he was riding a bike and he fell off, right? So this is very important. So it helps you to pretty much understand what we are seeing, right? So again, so what are we going to do now? So we don't have to intubate at this moment, right? We don't have to. So we are focusing on two things: his neurological condition, and the fact that his heartbeat it's bradycardic. So what are we supposed to do? Do we run an EKG? Maybe the pulse oximeter is giving us a false reading. Right? This is something on the bed. It's something right. It's a trauma case. We are ER's doctor, right? We can pull out the fast doctor, right? And then do a fast and see what happens, right? What else can we do? Put him on a drip, Give him, get some blood tests done, right? With a cross match. What else can we do? Is that? Oh, put it on the box up. Got it. Next slide. All right, so this is pretty much what we're talking about. Would you like to know anything else? I mean, we went to that, right? We went to the referral, we went to the helmet, we went to medicine, right? So what's your initial approach, right? So again, Dr. K, right? We fall into that situation, right? And I don't blame anyone because we want the system to work, right? So everybody does his part, the four parts. And that's where we say, look, let's see the referrer who's sending him, who got in contact with. So that's important because that's going to help the system work. Well, we're going to get sooner into diagnosis and differentials. We talk about the diagnostic tools. And then once we set the diagnostic tools for whatever we want to ask or do the test or imaging or blood test, and then we're going to look at the results. And then once we get everything together, we would know exactly what to do with patients. At this point in time, we haven't seen the X-rays, we haven't seen the blood test, we haven't seen what is clicking in your mind? Because we have someone and we want to know what they have, isn't that so? Right? So what's clicking in your mind, right, in this case?
Taking into consideration a trauma, would request for a trauma series. Right? Want to see, trauma patient, Glasgow drop, we also need to see chest, pneumothorax, even with saturations and everything, we're good. We've seen cases in which we have pneumothorax and it doesn't We need to see the level of fracture that the patient has at the management.
I think that's actually what is your major concern? What is the
What's
concern?
alarming?
Right. Okay, so, yeah,
Why do
it's
you
not
think he was
clear.
sent? Why was he sent, bro? What's the
It's
reason?
probably due to a head trauma more than anything. So by this
That's-
time, we already have over. The thing is,
Yeah,
no, the
we,
thing is when we have a,
that's the beauty of bringing up cases like this, you know. You're gonna see at the end exactly what happens. That's, it's very important. You know.
the way we work at the ending of the because, like you said, we would mention time.
I don't mind.
We already asked, how long, well, we know already how, more or less what time, how long the patient, what time the patient will be here. So, and we have a thing where our systems are connected. So I don't know how you, whenever I receive a case, I go back into the system. I already have a name. I already have a BHIS. So if the patient does have a previous history in the system, I can go back and, like you said, check everything out, everything before the patient is here. The nurses are already preparing because you have told them this is coming, this is probably what we can expect. So the nurses already have told almost everything. Now, so when the patient gets here, you already have an idea. And I guess you already kind of have in your mind what you will do,
So
what you will ask
this
for.
case seems to be RTA, Philadelphia, is confused, plus for flow. Seems like a head trauma, seems like the next reasonable step would be A, let's do a CAT scan. Because something is gonna happen. Is that so?
Yeah, in relation to this stuff, many times we get calls from health district and they refer the patient and the first thing they tell you on the phone sometimes is that, okay, we're referring the patient and we want them to stop at PME or PHPL before they come to PHMH for the scan. Sometimes, you know, after their assessment with the patient. And that's one of the main reasons because they don't have CT scans.
Okay,
available
so
outside.
at the end, we're gonna get all of that, all right? Even though the case came to us, again, that's fine. But again, we have all. So let's review. Next
It'll
slide.
come back up. Give it some time.
Do they have any focal?
No focal definitely, but I think it's things that's up in the storage, right? So pretty much that, right? So we have a head trauma. We want to feed them. He's already platinum compromised, so we want to kind of keep a closer eyes, like 30 minutes vital signs. NG tube, it's a head trauma, it's nauseous, right? Then you want to do NG tube. We're going to pull out the 3 tube, that is hematology, chemistry, and PPR. We're going to do urine analysis, right? You said it, Dr. right? The guy looks like he was drunk. You know, right? Maybe he thought because he's drunk, maybe he's confused because, you know, some type of alcohol, you know, encephalopathy. So we want to do a urine analysis. We want to do toxicology. I mean, this is just for the fact of learning, but you know, how toxicology is, right? And then there we go with the polytrauma. We're going to do a polytrauma X-rays, pretty much head to toe. We're going to do an EKG. We have bradycardia. We're going to do EFOS. You know, we want to make sure that, you know, there's no bleeding. We want to do a brain CT scan again. Riding bike, I mean, patient who's riding a bike who fell off and then compromised. We want to do a brain CT. We want to do a consult with the specialists and subspecialties. And then once we review everything, we will know exactly where the patient is going. Next slide. So what do we have there? What is that? What is that? What is that? What is that? Fast ultrasound. So, would you try? Anybody want to try something else? No, Dr. Moy is saying that's a fast ultrasound. It's an E-fast. So it does have component so it's an E-fast. And if you look around, right, you see anything abnormal?
Use the pointer.
Right.
So who wants to point out anything they want to?
You're right. You got me on that one. You got me on that one.
So this is basically one of the very most important that we use in the However,
you guys know
guys
that
don't
the
always
ultrasound machine has been down for a while. I think we should be getting a new one. But right upper quadrant, Morrison pouch, we look for the kidneys, which is the right kidney here. We look for the liver,
What?
the liver,
To sit?
and
I'm okay.
you look for this very important line right here. This is where we look for free fluid. If there's a black space here, then we know that there is free fluid in the abdomen. Most of you guys know it already. We do the similar on the left side. We go by the spleen, and then we go by the left kidney. If there's a bit of fluid here, or a black space here, then we know that there's free fluid. Free fluid as well. Right, so these I would consider as negative. Both of them would consider as negative. And as Rigo mentioned, well, the man ended up with an uterus here. So I don't know where that came from. And then this is a bladder.
He's not pregnant,
Yeah,
right?
he's not pregnant. It's a clean sack. A little bit like there's something
bigger
here.
than
Yeah,
some
contusion.
but it looks like we have
Yeah,
the loss of the
cortical
relationship
space.
between the cortical and
Yeah. But basically, we look here, and then this is even more important here because I have seen this before, believe it or not. And this was when we used to use an ultrasound. You see the space right here? This is the space around the heart, and you can actually diagnose cardiac tamponade. And I have seen cardiac tamponade with our ultrasound machine in the emergency room, and you would see the same space here, right around the entire circle of the heart. You would see a large space of blackness that's fluid. But this is a normal heart ultrasound as well. Anyway, let me hand over back to Sue.
Thank you so much. Thank you. Next slide. So we have a normal EFAST, right? So what about this chest X-ray? What are we looking at a chest X-ray on a trauma case? Do you see any of those? None? Okay, next slide.
Let me make just a real quick comment on chest x-rays in general. You want to, whether it's a trauma case or anything else, you always want to have a system, and it doesn't have, there is no right or wrong, but it's your system in terms of how you look at a chest x-ray. What do you look for? And you do it the same way that every time. You look at the ribs. Is there any rib fracture? Is there any clavicle? This is a classic trick that they use in radiology boards, is they'll give you a case presentation and it'll maybe kind of make you think that, oh my gosh, there's some chest injury or something like that. And the guy's got a broken clavicle. And you tend to focus just on the area. You don't want to get blinders on. You have to kind of really look at the entire thing. You can see shoulders here. You can see that this guy, in this case, whether this is this patient or not, but you can see he's not, he has open epiphysis, on his humerus. So he's not, this is somebody who's probably maybe 16 to 18 years old. I mean, that's not this case, but in this x-ray, no broken ribs, looks like normal cardiac silhouette, no pleural effusion, no collapsed lung, but the bony structures are all good. And you don't see free air in the diaphragms. It's not just lungs, you're looking at the entire thing. And you need to kind of have that approach to every chest x-ray that you look at. Okay, sorry.
Just to add one word.
I usually start looking at the trigger. It's centered, that means that the X-ray will be good.
Right.
So pretty much it. So the question here is, how do we know if the chest X-rays it's well taken? If this is a good quality chest X-ray, how do we know that? Well, let me tell you that. So as Rigo said, we have to make sure it's not rotated. How do we know it's not rotated? Well, we go take the middle of the spine, right, and make sure that that center equals to the same to the clavicle end, to the proximal end of the clavicle. So you take both clavicles, the center, and you make sure that that distance is similar on both sides. So that is the non-rotating chest X-ray. So, but we also need to have a well-penetrated chest X-rays, and then we kind of count the spaces between the vertebrates. You have to count the space through the heart, through the heart cylinder. You have to see the spaces of the vertebrates, and that's tell you how penetrated it is. So, but what about inflation or insufflation or inflation of the lung? So, we need to have, if you count in the back one, you have to have 9 spaces. These are the back ribs, right? And the circle one and the front one. So we can go 1, 2, 3, 4, 5, 6, 7, 8, 9. You have to have at least 9 to see that it's well insufflated or inflated. So those are pretty much the 3 elements of an X-ray. So okay, this is a quality X-ray. Next slide. So again, right, we were concerned about his bradycardia, and this is what the EKG says. This is a 6 leads, this is a 12 leads X-ray, EKG, right? And yeah, the little squares are so tiny, but do you know how to tell what the heartbeat or what's the heart frequency? Just by looking at the EKG. Right. We have the 300, the 150, 175, 60, 54, and so on, right? So he was indeed 46. Right? 46. That was 46. Next slide. This is what we were all waiting on. See anything on the brain CT? Oh, look.
It's not bone window, right? So we're looking at bone. Basically, we want to look at the uterus, right? Everything is homogeneous. The reason here, that looks suspicious to me, of this hypodensity, but I don't see any clear areas of bleeding. That would be one of the biggest concerns, bleeding. And apart from that, the midline looks, when you say that the ventricle looks okay.
I think in this case, what we will be looking for really is epidural or subdural hematoma. And there's no obvious epidural or subdural hematoma in this case here.
Remember you mentioned that the eyes amniotics.
And so if you had some kind of pressure there, and if it's on, you didn't mention it on both sides. I think it was both sides. Yeah. So you would have some type of pressure building up in the cranial cavity, and I don't see any pressure building here from the CT scan. It's just my opinion.
All right, so we come to the conclusion the CAT scan is normal. Next slide, please. And then we mentioned that we need to have a trauma series. All right, it's a bit rectified. I do not see any. I'm sorry. Anything? See anything, Dr. Holt, Dr. Su, Dr. King? All right, next slide.
So how do you guys read a cervical spine X-ray? And what's, if you only had one X-ray, which of these 2 X-rays would you want to see? The one on the right, correct? The lateral? Okay. So how do you, what's the process that you, let me have the pointer for a second. What's the process that you go through to read especially a lateral? You're looking at both. Sorry about that. That's all right. You're looking at both, but let's go back up. There's a few key aspects that you're looking at.
Can I ask them?
No, don't worry about that.
Ask them if they're seeing it. Ms. Wilson.
I'll turn the sound back up here for a second. Can you guys see the screen okay? Dr. Essler and Saran?
Yes, I can see it.
Okay, all right. So the key aspects here, first of all, is number one, it's straight. Okay, that's good. And actually, it's almost too straight because you have normally a little bit of lordosis associated with the cervical spine that's normal. So here you've got what we would call loss of lordosis. So that's almost like somebody it's too straight. Sometimes you see that with immobilization. Sometimes you see that with muscle spasm. And this guy is probably far enough post-injury that he very well could be developing some muscle spasm. But in terms of the bony structures here, and first of all, if you're going to have any kind of cervical injury, a lot of times you're going to have a cervical hematoma. And that's going to be a soft tissue bulge here. And you basically, this prevertebral space is very, very critical, especially 1 through 4 here. And you don't want to see that more than about 2 centimeters. And so if you see a bulge that's kind of in through here, whether you see a bony injury or not, you've got to be very suspicious that there is a cervical injury. But also there's 4 lines that you want to look at. Number 1 is the prevertebral line, and this should all line up good. The second one is this posterior line right here, and this all should line up. You want to be sure that you've got an adequate view of all the vertebrae. You got 1, 2, 3, 4, 5, 6.
I'm missing the 7.
Can't see 7, and you ought to be able to actually see the top of T1, okay? And so you really have to be very careful here because of the adequacy of this, because you really can't see that down here. Okay, but what you can see is that all of these lines, these lines line up, and these lines line up. So just kind of on a quick and dirty read on your lateral 1-view X-ray, you're going to catch about 90% of your cervical trauma on this 1 view. And you'll see enough here that may need you, oh my gosh, we now need to get some advanced imaging, but you're going to CT the head anyway. Let's just go ahead and CT the neck too, because that's going to really allow you to see definitively any cervical injury. So again, just having a system in terms of how you look at an X-ray is really, really important so that you don't miss things. And boy, you don't want to miss anything in here.
Next slide. Those are the thoracic spinal column. Looking pretty much normal. Next slide. Lumbar spine.
There's arrows. And when the radiologist puts arrows on the X-ray, you better pay attention. Want me to go on?
Right, next slide. So we're going to take that as pelvis X-ray.
Why does it look normal? Again, how do you look at a pelvis X-ray? Because this guy's got a mechanism of injury that is certainly very suspicious for, if you can just, that's very suspicious or puts him at high risk for a pelvic fracture, right? I mean, motorcycle injuries in general, RTAs in general, but this guy in particular. So when you're looking at a pelvis X-ray, yeah, you look at it, you don't see anything real obvious, but sometimes pelvic fractures can be subtle. And so you want to look at just kind of the big picture here. There should be several circles here that look good. That looks pretty good. This looks pretty good. The interior pelvic rim looks pretty good. You don't see any step off of the bone through here. This looks pretty good. You don't see, and again, any incongruity, any abnormality associated with anything there or there. Inferior, superior pubic rami fractures. And obviously, you're not just looking at the pelvis, you're looking at the hips too. And so as far down as you can see, all the bony structures here look good, okay?
So that's normal pelvic X-ray. Next slide. That's the wrist that we all wait to see. That's the wrist that we all wait to see, right there. What is that? So it takes knowing, reduction, and casting, right?
And this, one other thing that I would point out on this one too, is that on this fracture, one of the things that is remarkable to my eyes, I haven't seen this before this presentation, but this fracture goes up into the joint, okay? You can't see that clearly, but you can clearly see that this is a T fracture. It fractures across here, then it goes up into the joint space, and then here you've got the ulnar styloid too. But this is a potential problem because fractures that involve the articular surface, if it's not properly cared for and it's not badly displaced, but it has potential for developing a post-traumatic arthritis. So you got to be really careful in terms of, again, getting your orthopedic colleagues involved with this too in follow-up, okay? I want to get you in the picture too.
So, next slide. So, some of the blood tests that we have requested, look at the urine analysis. That PAC is the blood alcoholic content found in the urine. All right, we're not familiar with that, but that is high. What is the normal value of that? Should be zero. We have no alcohol to be zero. So that one, that may explain why he was unclean. Maybe. If you look at the hematology, it's looking normal, decent, right? And the chemistry, somewhat going on. Right. Next slide. Next slide. Do I have a next slide?
That's last slide.
So what do we have then? Brain CT, X-rays normal, fast normal. So what do we have here?
AKI due to intoxication and cause dehydration.
Okay, I agree. I agree. Alcohol intoxicated. So let's do the management. So what are we going to do with that? Yeah. Right. You're right. I mean, the reason I stopped said to kind of dip a little bit on the alcohol level is because we already found problems, right? So the guy was alcohol intoxicated. So we're gonna write off fluid, thiamine, T5, dextrose. So we're gonna cover that up, right? And then what else we have? What else we have? So yeah, we.
So what is your explanation for his bradycardia? We get what? Well, I don't know if he has had any medication or not. So.
All right. So but you see how interesting the case looks like, right? So at first, again, fell off my head trauma. We were kind of suspected that he might have some brain, right? So can you go back to the first slide of the group? Right? Yeah. So we right? Right. Right. So we getting there. I got the feeling that we're getting there. We're really getting to know the case, right? Getting to know the case. So let's go. Let's see the pieces. I mean, and the board exam that we sit and face. This is how they will give you the information, but we need to know what to do with it, right? So look for instance, right? He lives in PG rural, right? Right? Well, this look at the symptoms: confused, nauseous, agitated. What else we have? What else we have? And the biotic bags. That's telling us of something already. Right?
Right?
Right? See, it's telling us a lot, especially the meiotic pupils and the bradycardia.
The man was
The man was
the man was
the man was coming.
The man was
Well,
what?
let me not make it difficult, right?
So to complete the story, right? And this didn't know that the doctor who referred, they didn't know about the case. I know the case until I spoke to the wife.
Right? So,
where was he coming from? Or where was he going to? On his bike. He said,
and that's where the diagnosis comes from. And his wife said,
we have
a
a
farm.
And he was spraying out
organophosphate.
That's where the bradycardic and the meiotic pupil came up. Then I said, you know what he has? At that point, in fact, even without the CAT scan, so I
quickly, instead of calling the head trauma surgeon, I called you want me to go ahead and do the trial with atropine to see if this guy is indeed intoxicated with organophosphate?
Right? Are
You
you familiar with the trial of
atropine?
Yeah. Where somebody visited in water from a home.
So, on this case, you can either use 0.5 grams or 1 gram, right?
Milligram.
Sorry, milligrams of atropine, right? And just give it a push. If the heart beats, right, beats of more than 25,
right?
More than 25 beats, then it's mildly intoxicated. Right? Because the organophosphate and the atropine compete for the same receptors. So if his heartbeat picks up with the atropine, it has some receptors available, meaning that the organophosphate won't using enough to fire the receptors. Okay? And then of course you keep going, that will continue to get to atropine sensation, right? And then you stop. Well, what is that? How do we know that we stop here? I mean, if he doesn't have the symptom, but many times they might have cyalorrhea, like excessive salivation, then hearing, like he's crying too much, right? Or you see the pupil beginning to get dilated, right? Then you stop. But then at that point in time, that's as much as I went with him with atropine because that's all I need, right? No, while I was reading the case, I found out this. I'm taking the medication right now. Pralidoxine? Pralidoxine, right. Pralidoxine, all right? So these are anti-cholinesterase inhibitors, all right? And know the recommendation and treatment is, of course, to combine them, atropine and pralidoxine, right? And the dose to that is 1 to 2 grams, right? To go in 5 minutes, and then you repeat that every 15 minutes until you bring him back his weakness, his muscle weakness. Because if they're highly intoxicated, they become pretty much paralyzed. So you have to kind of do. So again, it took me some time. I don't remember how much time to get to that point. I said, my goodness, things can come in one way and happen to be another way. All right? Thank you, guys.
Comments?
Yes. Just something that I was looking up here, that caught my attention in the presentation, and I think this is something that you guys maybe all of us need to know. The people from meiotic, right? And I was looking up, and it says scars of pinpoint pupil. There's a mnemonic that's kind of pontine, right? And a pontine mnemonic means that you have pontine hemorrhage or pilocarpine, right? It could be organophosphorus poisoning, The N is for neurostigmine poisoning. The T, of course, is for trauma, right? The I is for inflammation of or causes from an anteroiditis. The N is narcotics, which can be like morphine. And then you have Eye-Horner's syndrome. So one of the things that causes causes of the mnemonic for pink eyes or eyes is the confined mnemonic. So just as a take my quote, that is something which you look at. Many patients come to us with pinpoint eyes or red eyes. And so we don't know this mnemonic is confined.
Exactly, exactly. And that's to remind me, but of course, then we have to be considering dialysis in this case, right? Because of what we already knew, he was already okay, because of the symptom that he has, and because of what the wife said, that's exactly what he was doing. But nonetheless, without knowing that, nothing wrong to have done the next way, trying to rule out the trauma. So he ended up in ICU.
Any other comments?
Yes.
He recovered?
Yes. They invited me to come.
All right. David, do you have any comments at all?
I have a comment. First of all, I'm in a very comfortable posture, so thank you for that. So trauma and medical presentations often coexist. So this is a classic example. When you're thinking trauma, it actually could be medical. And I think one of the best examples is someone who comes in, and I've seen this several times. They have a shoulder pain, and they say, I must have wrenched my shoulder. I was doing something strenuous. And in fact, they're having a cardiac event. I've seen that over and over. I must have. And they always want to ascribe a medical event to a traumatic one, and vice versa. So I hit my head, but in fact, they're having a stroke or they're having a dissection. So this is something that, the patients haven't read the textbook, and you can have coexisting medical and traumatic illness. So that's what makes the job challenging and fun. And I was kind of wondering what's going on with this patient. And then the history pulled it all together. And sometimes it's one little tiny thing in the history that pulls it all together. There was a case in Vancouver I'll tell you about that's a good example. It's similar. I think this was 3 years ago. They had a young man who was in ICU with encephalitis, and nobody could figure out why. And it was progressive over a week or two. And then finally, a medical student interviewed one member of his family who said, oh yeah, I remember we were out in the wilderness that day, and a bat flew by and touched him. And they thought nothing of it at the time, but the bat had rabies, and he, of course, they tested him for rabies. He had rabies and he succumbed. So that was a point in the history that came out a couple of weeks after he was in ICU, and they were trying to figure out, they had treated him for all the treatable causes of encephalitis. Anyway, I just think that's a great, great case, because as soon as you commit yourself to either a traumatic or a medical diagnosis, you may miss the other one, and you have to bear an open mind, and that's why our job is so very, very challenging. I'll stop there.
Okay, thanks, David. Questions? Byron? Evan? Karina? No? Yeah, nice job. All right, we are done, I think, for the day. We thank you, and like I say, I will send out Dr. Venezia's presentation to you all.
And I will
And I
also,
will
as
also,
I
as I
mentioned
mentioned
to
to
you
you
earlier,
earlier,
I'll also send you out my latest copy of the Annals of Emergency Medicine for you guys to read. David,
one thing that
has kind of that actually
Karina asked me yesterday about, and that was whether there were going to be reading assignments. And
I didn't have
I didn't
anything
have anything
yesterday,
but
as I thought about it overnight, I thought at least we can
we
start
can start
with
with
some current literature,
and
you may want to
give some thought to again some reading assignments whenever you come down to. Just FYI.
Good. Yes, I've already got some in mind.
Good. So with that, Byron, go home, get some sleep. And Evan, go to work.
And Karina, go home. Yeah. Thank you, guys, and thank you, all of you guys here.
Maura? Can you hear me, Maura? Oh, you unmute yourself, Maura. You can't hear me? Can you unmute yourself? Can you hear me now? I can't hear you. Unmute yourself. You're muted.
Now I'm not.
Okay. Good. Am I on speaker or is just you and I?
No, well, enough. You're in the room, but you're fine.
Oh, okay. You know what? I wanted to talk to you